Good evening. So with that, let me start my topic. Pyelonephritis and diabetes is what we are going to discuss. I'll present a few cases, 3 cases, and then try to define each, and then a little bit about pathology and radiology of pyelonephritis and microbiology and antimicrobials to be used, and most importantly, the long-term management. So first, I will discuss 2 cases. This is a 64-year lady who has been a diabetic. She has been treated for UTI very often, and she was admitted with fever, abdominal pain, reduced urine output. She had altered sensorium. Her total count was 23,000. Her platelet count was 1.2 lakhs. Creatinine has shot up from 1.8 to 7.1. And this was the CT scan, which shows air in the right kidney as well as the surrounding area. She had altered sensorium, which was persisting. So a CT was taken where you can see air in the sagittal sinus of the brain as well. So that was the first case. So the second patient is a 40-year-old lady who has been a diabetic for 7 years. She was admitted with abdominal pain and she was afebrile. Her creatinine was 0.9. Total count was 7,600. There was no pyuria and urine culture was negative initially. And ultrasound showed hyperechoic kidney, rhinomegaly. There was perinephric sanding. There was the radiologist impression was that it was acute pyelonephritis, and we had a call from the surgical side to take over this patient. So that was the situation. And third was a 50-year-old male who was a diabetic nephropathy, who underwent altruistic renal transplant 3 years back. He was on induction with basiliximab and triple immunosuppression. He was admitted with fever and leg swelling, and he had a tender graft also. His creatinine has again shot up from 1.6 to 4.0. So he again had an acute worsening of his graft and a tender. So the ultrasound, this is a depictive picture of the ultrasound, showed air in the collecting system, air in the surrounding tissue as well. And there was a perinephric abscess sitting in the posterior aspect, which is compressing upon the external iliac vein, producing a thrombus in the external iliac vein. So this is how 3 of our patients with whom there was a presumptive diagnosis of pyelonephritis came to us. So coming to the topic, as you know, diabetes is produces a very hyperglycemic environment, produces tissue hypoxemia, which is conducive to organisms proliferation. Then there is stasis, there is autonomic neuropathy and stasis. So again, conducive to organism multiplication. There are renal stones, there is drug-induced glycosuria and repeated antibiotic exposure. All these favoring antibiotic. Pyelonephritis in diabetes, as I said, it is the most common cause. Varied presentation, it can be challenging to treat, and very often results are gratifying, and long-term management is again challenging. Forms, it can be acute pyelonephritis, there can be renal abscess formation, renal papillary necrosis, emphysematous pyelonephritis, and pyelonephrosis. Diagnosis, we should make a diagnosis with a combination of symptoms. As I said, fever and chills and flank pain can be mild, may not be recognized. There can be nausea, vomiting, and shock. Pyuria, urine culture, and sonology can all be present in acute pyelonephritis. So coming to the pathology, most often it is a bladder inoculum which ascends up because of impaired peristalsis. It leads to inflammation of the pelvis, and the uretropelvis goes into the papilla and the parenchyma. And ultrasound in pyelonephritis, initial nephritis may not be well picked up. There is renal enlargement and loss of renal sinus fat. Echogenicity, there can be hyperechoic and hypoechoic areas because of hemorrhage and edema. There can be abscess and hypoperfusion. There is perinephric extension of abscess as it progresses. So very early on, it is just a dilated kidney or an enlarged kidney which is seen. And for an early diagnosis, contrast with a 90-minute film can be done, which shows renal enlargement. There is a striated or delayed appearance of nephrogram. There is delayed calyceal appearance time and dilatation and effacement of the calyceal system. This can be appreciated sometimes on CT. And if you wait further, that can be a wedge-shaped streaky stone of lesser enhancement that extends from the papilla to the cortex. So that is how it can be diagnosed. There can be inflammatory debris in the lumen as well. So there can be contrasting alternate hypo and hypoadenation. So this is how a contrast CT would look like in early pyelonephritis. Renal abscess, they appear as rounded or geographically low attenuating collections. They have a thin rim with a pseudocapsule formation. There can be halo around it as well. So that can be diagnosed with the contrast CT most often. very often it presents as pyelonephrosis, renal abscess or lobar nephronia. And pyelonephrosis is a grave condition where there is infection and obstruction of the collecting system. There is parenchymal pus formation. Immediate intervention is warranted because it leads to rapid decline or goes in for a sepsis. Most often it presents as a post-ureteric stent obstruction with pain. Stent pain in a post-ureteric stent patient with fever and flank pain. And it is very easy to diagnose and it needs immediate intervention. Emphysematous pyelonephritis, as you know, it is air in the parenchyma of the kidney, occurs in uncontrolled diabetes. There is underlying diabetic nephropathy most often. There is urinary tract obstruction, most likely to present as an acute kidney injury in diabetes. There can be renal capitis if you palpate them deep, palpate on deep palpation. There can be shock. There can be renal papillary necrosis and stasis. Very, very rarely they can present as pneumaturia as well. There are several grades. This is grade 1 in which the collecting system is affected. There is a stone there, but then we can appreciate the dilated collecting system. Grade 2 is when the parenchyma is involved. It enters into the parenchyma. Grade 3 is when it has gone out of the renal capsule but lies within the Gerota's fascia. This is how the fascia of the kidneys are. So it lies within the Gerota's fascia. Grade 3B is when it reaches the Gerota's fascia and comes out. Grade 4 is when it has gone out of the Gerota's fascia. Grade 4 is when it is bilateral. So that is how it is graded. We'll come to the significance later on. Microbiology, we have had microbiology evolving in front of us. This is one of the study from PGI where they grew E. coli in 77% of the patients, Klebsiella in 4.7, Pseudomonas in 7.6, polymicrobial, albicans, Brucei, glabrata, and Auris aspergillus. All of them were grown from the culture. So we have been evolving. First, we have been using the disc diffusion method or the Kirby-Bohr method, which is the gold standard. Then we went into Vitek where early growth can be detected. Then we have QIAGEN now, and we have the BioFire now. So we are looking at it from a genetic point of view. Coming to the common beta-lactamase producing enterobacterials, Ambler A are mostly penicillinase. The red ones are the ones which are resistant to carbapenems. Ambler class B are the ones which are most often resistant to carbapenems. AMC or Ambler class C is much more sensitive. So these are the type of cultures which we do these days. These are the genetic tests which we do these days. So this is one such panel which is available. This is from the BioFire where we have CTXM, IMP, KPC, MCR, NDM, OXA, and VIM. So these are the different genes of the ASBL variety. Now CTX and AMC enterobacterials are susceptible to cefepime. They are weaker inducers of AMC and withhold hydrolysis by AMC lactamase. So cefepime can be tried in if you get a CTXM or AMC patient, but carbapenems can be considered earlier on. Most often cefepime is sensitive in these patients. Treatment can be continued with non-beta lactams like fluoroquinolones or cotrimoxal or aminoglycosides and so on. So that is about AMC. Then CRE are carbapenem resistant enterobacterials. Very difficult to treat. Klebsiella and pneumonia carbapenemase, New Delhi metallobeta lactamase, Verona integron encoded metallactamase, imipenem hydroxy metallobeta lactamase, and oxacilinase. NDM, VIM, MP carbapenemase are being increasingly reported. So we have carbapenem resistant enterobacterials coming up. So the drugs available for the use in carbapenem resistance are ceftazidime, avibactam, meropenem, vabrobactam, imipenem, cilastatin, relibactam, cefderichol, ceftazolin, tazobactam can be used. Colistin also can be used in such situations. Another important organism which is emerging is the difficult to treat Pseudomonas aeruginosa. Ceftolozane, tazobactam, ceftazidime, avibactam are available. Imipenem, cilastatin, relibactam is also can be used. Colistin and demoglycosides are available. Cefderichol is what is awaited. Likewise, plasmomycin as well. Both these are, plasmomycin is a newer aminoglycoside which is supposed to be more effective in such situations. Colistin, we have been forced to use colistin because of carbapenemase. One must understand it has got a very narrow therapeutic range, therapeutic window. Colistin, CMS or colistin methyl sulfate is is a less toxic and a pro-drug. It has to be converted to colistin. Most often it occurs in the renal tubule. So conversion to colistin may be impaired in renal failure. So one has to be very careful with the dosing. It can be used in isolation or combination. Previously, we have used it as a combination. Now it is said that it can be used as an isolation as well. The dosing should be very important. It should be 1.5 million units 12th hourly on a dialysis patient, and 2.5 after each dialysis, and every 12th hourly and after each dialysis. So very important to manage the dose colistin properly. And newer combinations of BLBLI are available. Ceftazidime, avibactam, one must be careful. It is known to produce encephalopathy. Mirobactam, vabrobactam is not available. It's soon going to be available. Imipenem, cilastatin, relibactam is available. Ceftolozane, tozobactam maybe is going to be available. So we have several drugs available for the use. So in summary, this is how we go by in a gene panel is identified. CTXM, we can still use BLBLI combination. CTXE, BLA, IMP, we can use a combination of astrionum, ceftazidime, and avibactam. KPC, it is astrionum, astrionum plus ceftazidime and avibactam. MCR is mobile colistin resistance, very difficult to treat. If you get a MCR1 positivity, is difficult to treat. We have to use combination of drugs. NDM, as I said, is again carbapenemase induced resistant carbapenemase based gene. If one has to use imipenem, astrionum, ceftazidime, and avibactam, so very difficult to treat. OXA 48 again, ceftazidime, avibactam has to be used. Vim again, astrionum plus ceftazidime, avibactam has to be used. So once the organism is identified, it is easy to treat. But then getting the organism and getting the gene is quite cumbersome. Newer agents, EDTA with cefoperazone sulbactam is available for use. We have tried using it. It is useful, but in selected group of patients. And EDTA cefoperazone again is available. Cefepime with enmetazobactam has recently come into market. We are waiting for ceftazidime as well as plasminogen. Fungal balls have been isolated. Very often it is a urologist to give us the specimen. After URS or sending, some fungal balls are sent for microbiology. We have grown, most often it is albicans, non-albicans, Cruci, glabrata, and Orus. Orus is a dreaded pathogen which is being reported commonly, recently. And liposomal amphotericin continues to be the most effective medicine. It has to be used for 2 weeks or till the sepsis is over, and then continued with fluconazole. Flucytosine, I don't know if it is available, but it is also used in combination with amphotericin. Echinocandins, one must remember, is not very effective. Micafungin, some studies have shown to be effective in pyelonephritis. So once the diagnosis is made, it has to be decided whether to go for an interventional management or not. Ureteric stenting is often done if there is renal papillary necrosis or if there is emphysematous pyelonephritis with obstruction. So that is one way to get it done. PCD or percutaneous drainage can be done when the abscess is accessible through the skin. We have done it in a couple of occasions. Nephrectomy can be done, but then very difficult to get the surgeons and the anesthetists to get it done. So based on the CT scan classification, as I said, Fang and Seng's classification has been used as a guideline for treatment. PCD can be successfully used in the management of class 1, 2, and class 3A when it is confined to one kidney or within the Gerota's fascia. With class 3B and 4, when it reaches the Gerota's fascia, one has to have a strict vigil. Nephrectomy may have to be contemplated in these patients, but PCD or stenting has to be done if there is obstruction or if it is accessible. Altered sensorium, renal failure, and shock indicates poor outcome in EPN, and one has to decide on nephrectomy based on the progression in the first 24 hours. Long-term management, very often it comes to the purview of the nephrologist. Often the patient is not treated by the intensivist or the urologist, and it is completely under the purview of the nephrologist. And perhaps the most challenging aspect is to treat these patients without recurrence. As you know, as you all are where recurrence is the role in acute pyelonephritis, especially when there is an underlying diabetes. The ureteric stent has to be placed till destoning or till the recovery of renal function, at least when the renal function returns back to its pre-morbid state. Early stent removal has been advocated, but then we all prefer to have the stent on till the renal functions have recovered. And once the stent is removed, we have to ensure complete bladder drainage is there. Only then, if the bladder is completely drained, bladder recovery occurs. Bladder dynamics, either you do a uroflowmetry or a urodynamic study, it should be done to find out if it is an obstruction or a bladder dysfunction due to diabetic autonomic neuropathy. Cholinergics can be used if there is diabetic autonomic neuropathy. Alpha blockers can be used if there is prostatic hypertrophy. And long-term management, nitrofurantoin and fosfomycin do not concentrate in the renal parenchyma, nor does it achieve significant bacterial concentration in the renal in the urine. So it has to be used with caution in those with the renal parenchymal infection, pyelonephritis or an emphysematous pyelonephritis, and it has to be used with caution in patient renal failure because the bacterial concentration may not be achieved. Fluoroquinolones are bacteriostatic, but still can be used once the acute phase is tided over. Saropenem and cefepime are being used, but there are not many studies on it. One must understand that bacterial clearance may not be possible, and the patient may continue to have bacteriuria or pyuria. So very challenging to treat, but then we can take the patient along for many years and maybe decades with the symptoms. Empirical therapy. So from this, from our antibiogram and the 2024 guidelines, we have come to the conclusion that meropenem and aminoglycosides are used upfront in a patient with acute pyelonephritis, especially if there is emphysematous pyelonephritis. De-escalate once the culture reports are available. Try to be more focused. Continuous bladder drainage is done if there is a bladder outlet obstruction or an autonomic neuropathy on bladder evaluation. The treatment is continued with oral antibiotics for up to 3 weeks, and stent removal is contemplated once the system decompresses or when the creatinine touches baseline. Urine culture is significant till the patient is symptomatic or maybe within two months of onset of symptoms. So empirical therapy is difficult and it changes with the antibiogram. Now, the first case which I discussed was managed with the injection meropenem and amikacin. Klebsiella was cultured. He had carbapenem resistance, and we had to put her on ceftazidime, avibactam, and aspirin. Ureteric stent was placed. Continuous bladder drainage was done. He was maintained on cefuroxime and clavulanic acid. She had a creatinine drop from 7.1 to 8.1. This case was published and by the urology in the urology journal. And second case, the diagnosis of pyelonephritis had to be rejected because he had an underlying pancreatitis for which diagnosis was later picked up, and the radiological diagnosis of pyelonephritis was not significant, not convincing enough to make a diagnosis of pyelonephritis in this lady, and she continued to have abdominal pain. Finally, she had acute pancreatitis. Case 3 was a post-transplant patient for whom from the urine we grew CTX gene was grown from the urine on E. coli. He had a failed Foley's catheterization, so he had a stricture as well as a prostatic hypertrophy. We had to catheterize him after urethral dilatation. He had hydronephrosis, which was corrected by continuous bladder drainage. UDS showed an atonic bladder as well as an obstruction. He was put on he underwent a TURP later on, and he had a CAC, intermittent CAC for some time. And then he was put on oral apixaban, and he was put on ofloxacin prophylaxis for 4 weeks as well. He continued to go on for another couple of years. And in a patient with diabetes with PN, fever with UTI, always screen for pyelonephritis. In a patient with diabetes, suspect when a patient with diabetes comes with acute worsening of renal function with fever, suspect PN and screen for pyelonephritis. Manage aggressively if PN is suspected. Antibiotic susceptibility pattern has to be found out, and based on that, antibiotic should be given. Ensure long-term bladder drainage. Recurrence is the rule, but then if it is properly treated, it adds many years to the life of this patient. as I said, very often, if even though the radiologically the disease look very devastating, maybe if treated, you can add many years to their life. So, as I said, treating acute pyelonephritis in a diabetic can be challenging, can be gratifying, and perhaps rewarding as well. Thank you.